Coronary syndrome. Well, acute coronary syndrome comprises of unstable angina, non-ST segment elevated MI, and ST segment elevated MI, unstable angina or NSTEMI. Which is seriously compromised coronary circulation with potential risk for death for AMI. The clinical features or symptoms are angina at rest, retrosternal pain radiating to left arm, neck and jaw, epigastric pain, stabbing chest pain, and chest pain with dyspnea. Diagnostic criteria are prolonged angina at rest for more than 20 minutes, de novo new severe angina is seen, or recent destabilization of previously stable angina, which is called crescendo angina. The aggravating factors are increased myocardial oxygen demand in conditions such as fever, tachycardia, hypoglycemia, or hyperthyroidism, and exacerbation of lung conditions such as COPD and asthma, or hypovolemia, anxiety, or anemia. The ECG changes are ST depression, inverted T waves greater than or equal to 2 mm, which is seen in unstable angina or NSTEMI. No ST elevation or QS are seen, where the cardiac enzymes are normal, which can be repeated every 8 hours. Well, the patients with ongoing angina and extensive ECG changes are at high risk for developing infarctions. Must be monitored carefully with serial ECGs and cardiac enzymes. Management for unstable angina are aspirin 325 mg is given stat for analgesia. If aspirin is not tolerated, ticlopidine can be given, which is 250 mg twice a day. When giving ticlopenia, patient should be monitored for neutropenia. Nitrates. IV nitroglycerin 10 to 30 micrograms per minute up to 200 micrograms is given. During nitrate administration, hypotension or watch out for hypertension. If patient has mild pain, sublingual glycerol trinitrate 0.5 mg for every 3 minutes are given, or sorbitrate 10 to 20 mg thrice a day is given. Coming to antiplatelets, aspirin 325 mg stat followed by 75 to 100 mg once a day, and clopidogrel 300 mg stat is given followed by 75 mg per day. Prasugrel 5 to 10 mg with aspirin combination is given. Anticoagulants such as unfractioned heparin 1000 international units per hour in infusion is given, or enoxaparin 1 mg per kg twice a day, or warfarin 10 to 15 mg per day is given. And beta blockers such as atenolol or metoprolol is given. Statins are advised to all the patients irrespective of cholesterol levels, with the aim to achieve LDL levels less than 70 mg per deciliter. Statins such as atorvastatin or rosuvastatin is given. ACE inhibitors. ACE inhibitors are indicated in patients with reduced left ventricular systolic function. And calcium channel blockers, only if beta blockers are contraindicated, then calcium channel blockers are given. While giving calcium channel blockers, short-acting calcium channel blockers are avoided, such as nifedipine. Dialtazam 30 to 60 mg thrice a day is given. The rest of the treatment include the treatment of aggravating factors, detecting the risk factors, health style modifications such as diet and other habits, treadmill test on drugs for the stable patients is done, and depending on the outcome, revascularization for high risk patients can be done. Next, ST segment elevated myocardial infarction. Well, diagnosis is by chest pain, syncope, raised biomarkers such as cardiac troponins, other enzymes, and sudden onset dyspnea. Investigations are ECG changes include 1 mm elevation in limb leads or 2 mm elevation in chest leads. New left bundle branch blockage seen, and the elevated cardiac enzymes. Well, cardiac kinase more than 2 times the normal, or elevated SGOT is seen. LDL or LDL1 are elevated, and troponins are also elevated. Management is done by MONA, morphine, oxygen therapy, nitrates, and aspirin. Well, oxygen therapy if patient needed oxygen, aspirin 325 mg is given stat, followed by 150 to 300 mg per day. Morphine 5 mg intravenously given stat, and followed by 2 mg for every 10 minutes for pain relief. Well, if the patient presents with inferior wall MI, instead of morphine, Finargan is given 1.25 mg to 2.5 mg intravenously. Nitrates 0.4 mg every 15 minutes given, with maximum times of 3 times. Thrombolysis with streptokinase. Ideally, within 30 minutes of chest pain, thrombolysis should be done. If no contraindications and blood BT, CT, PT, other blood parameters are normal, thrombolysis can be done. Best response within 6 hours of chest pain, and can be given up to 12 to 24 hours. Indications for thrombolysis are typical chest pain, less than 12 hours of onset. ECG changes are elevated enzymes. Age less than 75 years. Contraindications are stroke, hemorrhage, which is hemorrhagic stroke within 1 year, severe hypertension, bleeding disorders, patient and anticoagulants, active peptic ulcer or gastric ulcers, surgery within the past 1 month, recent cardiac resuscitation, previous treatment of streptokinase, where urokinase can be given. Well, streptokinase 1.5 million units in 100 ml of saline run in 1 hour, where 750,000 units should be given in the first 20 minutes, and the rest of the 750,000 units should be given in the next 40 minutes intravenously. Hydrocortisone or Ravel is given for allergic reactions. If blood pressure falls, volumic expanders can be given, such as saline. Along with this, anticoagulants, beta blockers, ACE inhibitors, and calcium channel blockers are given. And supportive treatment is given along with the rest of the treatment.